physician practicing at the Mahavir Hospital, Hazaribagh. Today we'll speak about the latest update in the hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable disease, of which 27% are attributed to cardiovascular death, disease which affect 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with the hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with the hypertension did not get treatment. Medication are used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is the data of the WHO Lancet 2021. International Society of Hypertension has released the Indian Society Hypertension 2020 Global Hypertension Practical Guidelines. The inclusion of optimal and essential treatment paradigms attempt to address the issue, that is resource poor settings. Optimal care refer to evidence-based standard of care, and where essential standard refer to minimum standards of care to allow specification of essential standards of care for low resource setting. The American Heart Association and the American College of Cardiology has released scientific statement in 2021 offering new guidance for the management of stage 1 hypertension. That is, blood pressure is 132, 139 systolic and the diastolic 80 to 89 millimeter mercury among patients with the low asymptomatic cardiovascular disease risk. Among low-risk adults with the stage 1 hypertension, management start with a non-pharmacological therapy. If blood pressure remains uncontrolled at the 3 to 6 months, consider starting pharmacological therapy. Acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in the people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter mercury range substantially reduce cardiovascular adverse event in the STEP randomized trial, affirming the sprint finding of an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Finding from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from threshold to 130 to 150 millimeter mercury. With regard of the prognostic value of ambulatory blood pressure monitoring and the nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on the office BP measurement, but also on out-of-office measurements such as home blood pressure monitoring. 24-hour and nighttime BP measurement were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurement of estimating CV risk. For every 20 millimeter mercury of systolic and 10 millimeter of mercury of diastolic increment of BP measured at night, the risk of mortality increased by 23% and the risk of cardiovascular event by 36%. Most patients with hypertension required lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend five classes of antihypertensive drug considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of the lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of ACE or ARB with CCB or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of the known carcinogen, namely N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 100,000 patients would have received NDMA contaminated valsartan from Zhejiang, Hawaii, it's a manufacturing site where the highest level of contaminated were found. Every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 100,000 patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visit of more than 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with the significant reduction in endpoint, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The large study included a total of 19,084 patients, hypertensive patients, during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on high BP deferred during sleep. The RR reduction of CV event was significantly improved for the nighttime treatment when compared with awaking treatment. Thank you.